Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome our very renowned doctor, Dr. T. N. Ravishankar. Sir is MBBS, DFM, FCGP, PGDMLE, MBA Family Physician at Sudar Hospital, Chennai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is initial management of acute chest pain in family practice. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
Good evening and thank you IGCP for giving me this opportunity on this auspicious day. In fact, holiday all over this country celebrating the growth of in their farms and their paddy field. And let me also take you in for an important topic that always bothers a physician, be it a family physician or a physician or a hospital ER or whoever it is. The initial management of acute chest pain is a very smart work that need to be done to do the appropriate diagnosis and follow through, and that too in a family practice. Think about something which needs a hospital admission at times, but at the same time in a family practice, you need to identify appropriately and diagnose and refer or do the initial management, because the golden hour is there for most of the problems that happen today in the society. Like you have a golden hour for trauma, golden hour for a cerebrovascular accident, golden hour for an MI, and all these things. And when we talk about chest pain, we always feel that it's the heart that is always involved. But let us see some case scenario which we always come into account in our practice. I'm not going to give any conclusion on any of these cases, but then you try to decide before the end of it, you will be able to arrive at a diagnosis appropriately. This is a 35-year-old male who reports to a family physician with chest pain of 2 hours. Typically, an Indian population who arrives late always with a complaint. Initially, he always has his own diagnosis and then come later for the family physician to diagnose him at the earliest. He had a pulse rate of 100 per minute regular with BT 170, 97, almost reaching above the normal range. And probably earlier BP should also be known if the family physician is visiting the doctor regularly. His CVS was normal with no lung signs. He had no other comorbidity, and how do you advise and what to do and what to follow up, we will be able to decide at the end of this session. Next, go to another case, 35-year-old obese female. We have IT professionals all over the country because we rule the software, we rule the Microsoft, we rule the Google and everything from this country. The person rushes to the family physician with chest pain of 20 minutes. That's a typical IT people who always are very conscious about their health. They want to be active because they work overtime. They work too long hours. It was chest pain only for 20 minutes with no comorbidity or no accompanying person along with them. His clinical status of pulse was 80 regular with BP 130 78. Examination did not reveal anything. And every person of this caliber will always try to put that diagnosis, because more than the doctor, they depend on the net. And today you have an artificial intelligence, they would have put down their symptoms and got some opinion on the AI, and they would be requesting for acidity as she is on a regular fasting because to take care of her obesity, to reduce her weight gain. There's another common scenario in our country where fasting has been regular spiritually earlier, but today to reduce their weight, and people who are working in the IT industry who sit and work for long hours having the junk food all along when they are working. Case 3, this is a 20-year-old male with chest pain predominantly on the right hemithorax and report to the family physician. It was 2 days onset, gradually increasing in pain. With the temperature slightly on the upper side, 99.2, but then the guy had got a little bit of interest. With a pulse rate of 90 per minute regular BP was absolutely normal, 120/78. No cardiac or lung signs that could be picked up by the family physician. But on examination, the abdomen, he had a right hypochondrium tenderness. Probably the liver was a little bit palpable. These are three classical cases which any family physician in this country will be encountering in his practice day to day. And how do you evaluate an acute pain with patients? What's the main thing that you need to know in a ER setup or even in a family physician is a proper history and physical examination will provide most of the time an accurate diagnosis. The patient can always give you the history. You saw 2 hours of pain. You saw somebody with 20 minutes of pain walking in, and somebody who had a gradual onset of pain. And all these things have got a classical diagnosis behind them. And physical examination is very, very important, even in the present day, where most of the time the diagnostic features and diagnostic things are becoming the most important value rather than the history and physical examination. But physical examination can always give you an accurate diagnosis in most of the situations. But at the same time, you need to have a suspicion based on the history and physical examination and try to clinch in a diagnosis, which will help you establish a diagnosis. Before you tell the patient what you think and what you want to do, you need to tell them at least a differential diagnosis or at least which organ is involved so that the person gets mentally prepared. Somebody who's a very anxious person will always think it's a cardiac problem. Somebody who thinks that he's a fit, normal person, in spite of comorbid, will always keep telling you it's gas. Try to provide me treatment for the gas. Gas is one common complaint in this country. We are always misleading both the physician as well as the patients who always think that they are always fine and they just an amount of antacid or an amount of pantocid will always help them go through the whole crisis. But at a later stage, if we land up with a problem, we need to answer them. The type of pain may be acute, has maybe an hour or two, or sometime even if there are busy people, they try to come and say, I had some discomfort or two in the afternoon after my food, but then they will drop into your family practice clinic or they would have waited for to see their family physician. They come there at around 8 o'clock and 9 o'clock, and even that is also an acute pain because the pain had happened and going on for a long time within the day. And that has to be accounted as an acute pain. And that's a very common symptom in our country where the populations always overlook their acute pain and come down to the place of the physician at a later time. Somebody will have a chronic pain, what we saw in the case 3 of 2 days duration, when he had an icterus and he has a chronic pain. People have a tolerance. You need to assess the tolerance of the patient before you label them it is an acute or a chronic pain. Somebody who have a good tolerance will always come late to the physician or to the family physician and try to give a history that try to correlate the history that when they had the pain 2 days back, 3 days back, at what time they had the pain. These are all very important features in eliciting the history to note down the chronicity of the pain. When the pain has been chronic, I think the tolerance of the patient is also there. But at the same time, we have certain comorbids which can always mask the pain in a patient. Quite diabetic patients, they don't have a pain, and then only when they have an associated symptoms other than the cardiac, that they are going to come to you. A dull aching pain, some chronic ailment which the patient is having it for quite some time. He will be with the pain, dull, aching, not being interested in trying to treat it at the same time. It will need to be the attention because it might disturb his routine work and then he'll come down to have an examine for the dull, aching pain. Somebody who's a chronic alcoholic, a bout of alcohol is going to reduce his pain. But then the effect of alcohol goes away, he has a pain. And then again, he's a chronic alcoholic. By evening, he takes another bout of alcohol. The pain is relieved for him, and then he continues. These are symptoms, these are histories that need to be elicited. Radiation of the pain is a very, very important feature there in our practice. Cardiac pain, everybody knows, is substernal. And when there is going to be an involvement of the our hemithorax, that site of pain, that region of the pain is going to be there, either on the right side or the left side. When you have pain which gets triggered in certain positions, When you lie down, the patient has got pain, probably the dyspnea. Somebody who has got a pericarditis are definitely going to have pain when he's going to lie down. But at the same time, when he might be getting relieved when he's going to sit up, and that is going to help him. These are important triggering and relieving factors that need to be known to assess the type of pain and to come to a diagnosis which organ is involved. Radiating pain, quite often on the left arm, radiating down from the substernum. There are also pain coming from the neck down to the left upper limb, that more often due to the cervical problems. There may be pain on the right shoulder related to the liver and all these things. These are very important clinching factors that will help you to put down the diagnosis of which organ is involved. Some of the most common causes that can cause chest pain is in the gastrointestinal. On the records, it is seen that 40% of the time it is the gastrointestinal problem that has been the reason for acute chest pain. Quite often is the gastroesophageal reflux, an acid peptic disease. You might have a reflex esophagitis, and then there is also something called hiatus hernia. Somebody who lies down will have the pain. Somebody who sits up have pain more in the night. These are situations where history is very very important to elicit it and involving of the gastrointestinal tract. Cardiac pain is quite often very easy to diagnose if you have an every GP or a family physician. The present day concept is to have something like an ECG machine. Today you have an ECG machine on your mobile itself, and if it is possible to have easily to diagnose in a cardiac case what is the problem of it. Substernal pain associated with sweating, radiating to the left arm, somebody in between the scalp, both the scalp, you have an inferior wall or a posterior wall. You have a pain associated with coming down to the jaw with sweating, and the giddiness can always be related to a right heart problem. Right coronary is when the right coronaries are involved and the inferior wall is involved. You have a classical pain or interscapular going to the jaw, exertion, and at the same time their pulse rate also would have been low. If there may be pain due to the chest wall, you have a tenderness in the chest wall, you have an injury, road traffic accident, you have a fight with somebody, then somebody punches you on your chest, you have a chest wall injury, quite common at simple costochondritis, or it may be a fracture of the ribs that can cause a pain in the chest wall. Pericarditis is another one. You need to get a proper history of a previous fever or any cardiac issues that is already then persisting with the patient to know about the pericarditis. Classical of the pain increasing on a supine and getting relieved when you are sitting up, falling forward, that will also help you. Lung pathology is another common cause. Pneumonias, pneumothorax, pleural effusion, or all these things which can cause a lung pathology, which are cause a common chest pain. And if there is a breathing distress associated with fever, an acute pain, stabbing pain on the either side of the hemithorax can always be related to a lung pathology such as pneumothorax or anything. But in the pneumothorax, you can see that the O2 saturation falls down so fast, and that's an issue. And an infection of any of the chest wall or in the lung, you might have a tuberculosis, which can also cause an infective cause, and you may have a cavity or a consolidation, the simple bacterial pneumonia or a viral pneumonia, as in this present season, which can almost also cause a chest pain if are not been treated properly, and if you miss to find something on the skin. That's where examination is very, very important. You might have a herpetic lesion gradually coming on from the thoracic cage, and herpetic lesion is one of the common cause of a chest pain, a radicular pain that can be identified easily if you can examine the wall and the patient giving you a symptom of a burning sensation of a pain, intractable, disturbing his sleep also. Some of the comorbidities are associated, six factors that need to be known. Diabetes and hypertension are the two major killers in this country, which need to be recognized. And quite often patients don't give a history. They come and say, I have a controlled sugar. It doesn't mean that he doesn't have a sugar. It means that he is on diabetes, and he's trying to say that he is on well on control with sugar. And then if you try to probe him when he had his sugar examined, it will be long, long back, 6 months, 3 months, 5 months. and that's how the Indian population behaved. The same way for hypertension, they say, I don't have a BP. I was taking drugs once upon a time. Then my doctor said to discontinue since the BP was normal. But most of the time, he himself would have discontinued the medication and now present with you like that borderline case of 170/97, 170/98. We might be perplexed whether he was an hypertension or not. But then there are other factors that can give you a diagnosis whether the patient is a chronic hypertension or a pain due to the or the raised BP due to the pain that he has got. Alcohol, Indian population doesn't know to use alcohol, and most of the time, a chronic alcoholic can always have lots and lots of problem, either in the GI tract or in the liver. And if he has been consuming alcohol with improper diet, he can always have a cardiomyopathy, and the ECG may not be revealing the information that he has got a cardiomyopathy. You always have to depend on echocardiogram or use your judicious suspicion. This is the place where you have to judicially use your suspicion that the patient might be having a cardiac problem. Smoker, everybody knows either his lung or his cardiac is going to be a troubleshooter for his chest pain. A chronic bronchitis or an acute bronchitis or a pneumonia or an emphysema in the lung which gets ruptured can cause a pain. If it is going to be a small emphysema, the pain is will be tolerable and it can reach your place. Obesity can cause so many things, metabolic syndrome, that obesity can in reverse produce hypertension, diabetes, and all the problem with dyslipidemia associated with it. Dyslipidemia need to be assessed because quite often this country people follow the YouTube and all these things which say don't take statins. Statins can cause a lot of things, and if they have discontinued the statins and just be on drugs for their hypertension or diabetes, they are bound to have a cardiac event happening, and that could also be assessed properly whether the patient is on any of these dyslipidemic drugs or not. There is another problem with also with the dyslipidemic drugs causing a liver disorder, causing a mild elevated liver function, but that is unlikely to cause a pain in the liver or anything because the liver needs to stretch itself if it has to produce any pain, and that can happen only if something in an anatomical disturbance of the liver happens, like a GB pathology or something like that. Poor timing in food habits has to be assessed because of the working pattern in the present population. We quite often our younger generation in the IT industry are working on time along with the Americans or in the Europeans that their working pattern is different and they have a poor food habit. Most often than not, they skip their breakfast, have a small meal, have a heavy food in the night, and come in the morning with a gastrointestinal disturbance or early in the morning with a poor cardiac reserve function or anything. Drug intake is another issue that we need to be probing into it. There may be people who are on aspirins for a long duration. Somebody with a rheumatoid arthritis having steroids or a chronic bronchitis patient with steroids. The drug intake will have to be assessed. All these things are assessed, can be assessed hardly in a minute or two if you are strong enough to get the history from the patient. And if the patient is not able to give a history, a proper attender along with them will be able to give you a good account of the about things. Some typical signs that you can pick up in a chest pain: a local tenderness, teeth syndrome. Even in a myocardial infarction, there are times when you can press on the sternum and try to find a local tenderness. That's possible. It does happen. A referred pain from the cardiac can always produce a pain over the sternum. And be sure about it. But if there is going to be pain on either side of the ribs, you need to account it more towards a pulmonary cause of a chest pain. Pain on chest movements is classical when there is an injury to the chest wall, when there is a fracture on the ribs, or when there is a pneumothorax, or when there is an injury to the chest wall with no other complications. The heart sounds are very important. Sometimes you have a third heart sound when there is going to be a rapid deterioration of the cardiac function, causing a gallop, and that can be identified when you are trying to auscultate with these patients who come a hour or two later, or you have a bad heart and you have an infarct and the heart is failing fast. You can pick up the gallop easily. Pulmonary signs such as rales and bronchi, quite often when there is a pulmonary edema or a left ventricular functional disturbance, or when the rales are localized to a particular area of the lung field, you have to associate more with the pulmonary pathology. Somewhere you have a cavity, you have a bronchial breath sound that can be easily identified. You have a coarse creps at one point in the lung or in the both the bases of the lung with the crepitations that can lead you to say that the patient has got a left ventricular failure resulting in the fluid accumulation in both lungs that is causing the RALs. A palpable liver in abdomen or a JVP. In fact, when you palpate the liver, the JVP also goes up. When there is a right heart failure, the JVP is obviously seen, and A sign, A wave will be very much well seen. And if you have a palpable liver, it can be a left ventricular failure or it can be a problem of the liver pathology. You have an abscess of the liver, you have a cholecystitis with a stone in the gallbladder trying to be into the CBD that can be palpable and can cause severe pain. Epigastric tenderness is one which is there common with almost all the people in this population. A spicy diet, untimely food, and you go on fasting on certain days in the week, and all these things can cause an epigastric tenderness. When there are reduced lung sounds, you can pick it up that there is going to be a pneumothorax or there is going to be a pericardial effusion or whatever it is. Pericardial effusion can cause a diminished breath sounds, but it is the pleural effusion that can cause reduce in the lung size. Skin lesions, I already have recollected that the very important finding of a skin lesion is associated with a herpes zoster infection in the thoracic cage. Some of the causes of chest pain in MI, pulmonary edema, pericarditis, myocarditis, very very classical. In this season, after a viral fever of 2 3 days, when the patient complains of chest pain, you need to have a suspicion. The patient could go in for a myocarditis. Don't believe he's an young person; he will not get myocarditis. Or don't leave it off even in an old age when the fever is not there and they say the fever was there a week or 10 days back. I'm here for well for the last 5 6 days. Always have a suspicion of a myocarditis at that point of time because it needs an hospitalization and it needs an intensive management, intensive care unit. Angina pectoris is very difficult to diagnose because there is no signs or symptoms that can be there. It only thing gives an indication that the patient had got earlier been on any cardiac drugs or any coronary dilators, and now today the patient has exerted himself to the point that his cardiac reserve is not there, and the patient will have pain. Either the BP or pulse will not be giving you an information whether the patient has got an angina pectoris. Non-cardiac pain, pulmonary embolism, somebody who had a surgery and then be on rest for a long time. Somebody who has an orthopedic surgery, an abdominal surgery, and he's been there at home for quite some time, not doing any movement, just been lying in the bed, getting up in the morning for his bath, for his breakfast, for his toilet, and then lying in bed for some time, 2 3 weeks. An elderly person, 50 years, or even a younger person with an amount of smoking habit and all these things, they can be having a pulmonary embolism, which is another painful one. Pneumothorax, pneumonia, pleurisy, we have all seen, and pleural effusion. Pleural effusion doesn't cause much pain. It's a gradual onset. Most of the time, patient gets accommodated. They might be landing up with you with loss of weight. If it is going to be tuberculosis, at that point of time, you need to evaluate him with a radiological and find out that the patient has got a pleural effusion. GI cause, GERD, esophageal spasm, chronic alcoholic Malarivi syndrome, cholecystitis, pancreatitis more often on the left side, but that also can cause pain, substernal and epigastric and all these things. We have seen about the chest wall pain, herpes zoster and everything. It's been repeated. When you are done with a history taking and when you have a suspicion, you need to go towards an appropriate investigation that is possible in family practice. ECG machine is the one which is there. Even with your mobile, you can have it. It is just certain applications are there which can help you to find out the patient has got an MI or not. See, if the patient doesn't have an MI and you are referring the patient to a hospital, the initial amount of expense that he incurs in the hospital, the next time he will have a doubt to come to you when he has an acute problem. The physician might be referring immediately to the hospital without an appropriate diagnosis. When you are trying to do an investigation or when you are trying to refer the patient to a hospital for an admission, you must be damn sure at least 70% that your investigation and your referral is going to be positive for your diagnosis. And that is why you get proper history taking and a proper evaluation, finding out the signs is very important. An ECG machine in a family physician's clinic is of utmost value for an early diagnosis not only for an early diagnosis, but also on an economical front and also for your reputation in the society, that you can have your cardiac evaluation done with your family doctor at any point of time. That's very important. X-ray is not possible today, but an X-ray of an AP or a PAVU is needed when you're suspecting that the patient has got a pneumothorax injury or whatever it is. Cardiac enzyme troponin I and T is possible to be done today. These are all card tests that can be done in a few minutes in your outpatient practice itself. Pain of less than 6 hours duration, tropi, and if it is more than 6 hour duration, trying to do a trophy, or if it is going to be more than 2 days pain, you can always find out a trophy. When you are referring, if you are going to refer that the patient has got a cardiac issue for the chest pain, your value in the society, your reputation with the hospital where the patient is going to go. More than that, your reputation with your patient is going to be there on the higher side. A CBC ESR is very important, and today every person has got a sugar that can be done with an easily with a glucometer. The other two tests are to be referred to the appropriate hospital to be done for an ultrasound abdomen and a CET chest to find out the cause of the pulmonary problem, or to find out the cause of anything that has happening in the abdomen, like the cholecystitis or a GB pathology or whatever it is. Investigation, as far as a GP is concerned, primarily it is picking up the clinical signs. And if you have a sugar to be done, if you have a cardiac enzyme, and if you have an ECG that can rule out the cardiac cause, and then you can make the patient, and the treatment depends on trying to observe the patient for a reasonable time. If it is going to be cardiac, I think the earlier the patient will need to be referred to their appropriate cardiac center. Otherwise, sometimes the patient can go in for an arrhythmia, which can be fatal in your outpatient clinic itself. But reasonable time should be assessed, and that is where an ECG machine or a TROP-T or a TROP-I will be very useful to keep the patient for a reasonable time to observe. And if there is not going to be any cardiac issue, repeat the ECG after 30 minutes or repeat the ECG after 1 hour. And if there is no change, you can be damn sure that the patient is not having a cardiac issue, unless otherwise he is a known diabetic with the signs and symptoms not getting revealed at the earlier. Pain relief is the one that needs to be given. One of the senior doctor here used to tell that his teacher used to say, the first symptom that the patient says should be given the earliest relief. And that was the one that needs to be relief. And all these patients will come in and say, he has got a chest pain. And if he says he has got a breathing difficulty, go down to the last stage, that nebulization is very important. Or in between that, the oxygen has to be seen, and oxygen level to be monitored, and then supplement with an oxygen. Today, a family physician can always have a small B type or still a smaller one-ish. And a mobile oxygen carrying unit is there today that can be there, or even the oxygen concentration, presence of an oxygen concentration and ECG machine in any family physician's clinic will be of great support, and it will be of helpful in the golden hour. Maintaining the BP and pulse can always be done with a little amount of IV fluid started before the ambulance arrives for the patient to be shifted. And if there is going to be a drop, an inotropic support, if there is going to be a bradycardia, an atropine can be given. And if there is an arrhythmiasis, even a cardron can be pushed as a bolus, so that the patient reaches the hospital at a much better rate. And your treatment, the golden hour treatment, is of great value to bring up your reputation in the society. Loading dose for cardiac pain is well known to everybody, aspirin, copilet, and statins. And nebulization, if there is going to be a dyspnea, that the nebulization is going to be helpful immediately. Give it in a phased manner, give the appropriate dose, and try to find out whether the patient has got a COPD, chronic bronchitis, or whatever it is, and try to provide it then. Intubation, today in Clinical Establishment Act, in my state, they want every family physician to know and have a laryngoscope and an ET tube, and then try to intubate. If the patient is on a respiratory failure, going in for a respiratory distress, if you intubate, relieve the distress, give them a bit of ambu bag, and then take care of the failure if there is going to be, and then refer the patient. Your golden hour is being done by the family physician, and that is going to be of great benefit for preventing a catastrophic event for the patient, because the longer duration of poor ventilation to the brain can always lead in for a vegetative state. And referring to the higher center must always be done after stabilization, and giving an appropriate staff accompanying the patient. Even if it is going to be an ambulance from outside, it is better that your staff also accompany them until the point that the patient reaches there. It is the duty of any physician or any family physician that the patient reaches the hospital where he chooses or where you refer with an appropriate support so that the patient is taken care during the travel. And quite often, I have already told you about the misleading histories that can always be done. I took a non-vegetarian. I take junk food. I took an oily food, and that is why I have this problem. But then finally, it will not the gas that is the problem. It is the myocardial infarction that would have been the problem, or a cholecystitis for the obese person whom he saw is it could be a problem. Always they always attribute to the insomnia. It is they always say they don't have a good sleep for 4 days, but then you find them they'll be sleeping in the afternoon quite well, that they are not able to sleep in the night. But insomnia should always be taken care because anxiety and depression is the other one which can always cause a chest pain. The patient coming to you trying to get your attention and attention seeking of the family and attention seeking of the family physician. The second case I put down was mainly that people try to crash into your outpatient clinic if they see more than 3 or 4 patients waiting, and you take at least 5-10 minutes to see a patient. They always say they have a chest pain and come into it so that they get your attention at earlier work. Overwork, you lifting heavy object. I took water for my home. I carried water for my home. I lifted something from the top almara, and that is why that has been a problem. All these overwork are done by people who are 50, 60, and then that would have precipitated a myocardial infarction. Had a slip at home, but it would have been a road traffic accident. At that point of time, you need to elicit an appropriate history and try to inform try to convert it as a medical legal case from that point. You are the first receiving point that who has obliged to inform the police if it is going to be a medical legal case. A slip at home is always a wrong and misleading history that they give when there is a road traffic accident. He might be involved in his car hitting another two-wheeler, causing a distress there on a worst accident, or he might be on the two-wheeler side that they doesn't want to give any information to the police. But then after 3 days, when the patient has got a pneumothorax and died or anything happened, they will then come again to you, and then that will be a problem for you to handle the police at that point of time. In spite of having done the provided the best of care at the initial point, you will be landing up with the medical legal issues. I think I have taken you through for a brief 30 minutes account. I think I have crossed my time also. 30 minutes, what is possible from my side, I have given Elizabeth. And thank you for this wonderful opportunity on this auspicious day where the cows are given the more important today in my state as well as all over the country for a festival that is to celebrate that. Thank you, IGCP, for giving this opportunity.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yes.
Yes, sir. So, the first question is, how can a physician differentiate between cardiac and non-cardiac cause of chest pain in primary care setting?
Comorbidities, you need to find out the comorbidities, the duration of the pain. If there is a localizing sign away from the sternum, it is not going to be a cardiac pain. Something which is associated with sweating quite often, even in a diabetics, most often you do have a sweating. And an intractable pain. That one other thing that need to be also seen is most of the time the cardiac pains is not continuous in nature. It is intermittent. You have a pain for 15-20 minutes, then you have a relief, and then again another pain. That is the reason why these patients come to you a little later. Cardiac pain radiating where it is to the jaw, interscapular, onto the left arm, associated with sweating, more often with the comorbidities. All these things are a classical feature. There are times when these cardiac patients will have a prodromal stage of 1 or 2 days, and the pain keep coming, settling down. They say they took an antacid, they took pantocid and got settled down, but then they do have some difficulty in performing their normal activities, like climbing stairs or walking a longer distance. And that is where this history eliciting is very important to find out it's a cardiac or non-cardiac pain.
Thank you, sir. There is another question. Which physical signs are red flags indicating the need of immediate referral or hospitalization?
You have a very bad pulse rate. You have a collapsing pulse. You have a severe bradycardia. BP not recordable. Patients drowsy, not responding to your call, and your GCS is very low. and somebody who has an intractable pain known to be a diabetic or a hypertensive or an alcoholic. These are three situations then that you need to refer the patient with an initial amount of resuscitation with IV fluids and run the patient immediately. Red flag sign depends on a simple pulse. Your pulse not recordable. Pulse volume is very poor, irregular pulse. Then there is an arrhythmiasis that is going on, probably only due to a cardiac event. Your BP is not recordable. There is an asystole. Because of the asystole, there is no pumping out of the blood, and there is going to be a drop in the BP. Two major things is going to crash down his conscious level. He is going to have a poor cardiac perfusion, cerebral perfusion, and that is going to cause his drowsiness. Three major conditions where your pulse, BP, and the cerebral status is poor, and there is an irregular cardiac rhythm. They need to be immediately be referred, even if the patient are a little bit stable as per your clinical examination.
Thank you, sir. We have one last question. When should aspirin or other medication be administered in the office before referral?
All patients you suspect who has got a cardiac problem, you think you are sure he is a diabetic and an hypertensive, and you have to just reassure yourself that he doesn't have a gastrointestinal pathology like a chronic alcoholic, a previous ulcer, previous surgery done for any of his cardiac gastrointestinal issues. Then at point of time there is no harm in giving an aspirin. Aspirin's contraindication in any of these patients is only if they have a gastrointestinal disturbance, if they have a gastrointestinal surgery, or a bleeding diathesis, hemophilia, or something like that. Only in these situations, or in a viral fever case, you suspect myocarditis. Present scenario is a dengue, where your platelets are low. You don't want to precipitate an event. Or somebody with a cirrhotic liver with portal hypertension already on pantosins or something like that. These are the situations where an aspirin will be contraindicated, and you need to, and you can give aspirin on any other cases. Somebody with a liver disorder with a cirrhotic liver, somebody who has got a gastrointestinal problem, somebody who has got a hematological disorder in this season, with somebody who suspected dengue with myocarditis and all these things, you don't need to give. Rest of the cases, there is no harm giving an aspirin. And along with it, you can always give a pantocid shot or an oral pantocid.
Thank you so much, sir, for answering all our questions. So, sir, before concluding, any take-home message from your end?
Thank you for giving a good opportunity. If a family physician will have to bring up his reputation in the society, his referral should be appropriate. Not referring every patient sees that he has got an acute chest pain. It is easy to diagnose a myocardial infarction in a family physician's clinic or even suspect any other diagnosis. And when you are referring, your referral should have a positive note at least 70% of the time. And that's very important in the society. And the golden hour, we are the primary care physicians. We are the one who is responsible for the golden hour management, and we need to have your ECG machine, the oxygen support, your enzyme studies are very important. I say this not only for the patient's sake, also for the physician, family physician's sake. It's also an economical reward for you, and it is also going to reward you in the society for a good work that you have done or a comprehensive work. Comprehensively taking care of the patient is very important, and that is what the golden hour management is there in the hands of the primary physicians of this country. Thank you.
Thank you so much, sir, for joining us today. With your permission, I would like to conclude today's session. Thank you, sir.
Thank you. Thank you. Thank you.